And thank you so much for joining us today. My name is Stephanie. I'm the Head of Programs and Research at CFCC, and it is my absolute pleasure to take you through today some of the highlights of this year's North American Cystic Fibrosis Conference, which was held in early November. So I had the absolute pleasure of attending from CFCC. I was amongst about 5,000 attendees, and there were representatives from about 33 countries attendance. So definitely the largest event for research in the CF space. And so this is a great opportunity to, of course, share knowledge and importantly, to bring these learnings back to Australia to inform the work that we do. So I do hope you are able to learn something new today. Like I said before, we do have, I'll go through a bit of a presentation about some of the key learnings, but we will leave time for a Q&A at the end as well. So please do pop any questions that you do have in the Q&A at the bottom there, and we'll get to them at the end of the session. So just a little bit of housekeeping. Firstly, recognizing that we are recording this webinar, so we will be able to share and you'll be able to view this after today. We'll circulate the link, and of course, for those who are unable to attend today, they will be circulating that as well. I do also want to acknowledge the researchers and the work that I'll be referring to throughout this presentation, who really contribute to the ongoing learning in the CF space, and of course the members of the CF community as well, who have participated in this research and have made these learnings possible. The conference did take place over 4 days, so really what I'll try to do today is give you an overview of some of the key themes and areas. And of course, with the time constraints that we have, I cannot do all the researchers' work justice. And of course, recognizing that nothing that we go through today should be interpreted as medical advice, because of course, everyone's CF is different. So please do consult your CF team if you have questions regarding your own CF and treatments. And with that, we will get started. So I do acknowledge that I am dialing into this meeting from the lands of the Gadigal people of the Eora Nation, and I acknowledge the traditional custodians of the various lands in which we are all dialing in from today. I pay my respects to elders, past and present, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands of waters of New South Wales and Victoria. So let's get things started by what is the lay of the land. So what was the context in which this conference occurred? And of course, we recognise that survival, as it currently stands for CF, has never been higher. So you can see here, this is data from the US data registry, which shows that at its most recent, the survival for CF, or median survival for CF, is about 56 years of age. So anyone born within 2018 to 2022, more than half of them are expected to live beyond 56 years of age. Now, this is US data, so we might be thinking, okay, well, how does this compare to the Australian numbers? And actually, it compares pretty well. So a November 2022 study that was published in Nature Scientific Reports took data from about 23 Australian CF centres and published for those born between 2016 and 2020. So slightly different period, but still quite very similar to the US data. That median survival for that age group was predicted at 56.3 years. We also recognise that for the first time, there are more adults living with CF than children in Australia. So about 56% of the CF population is currently over the age of 18, and that's from the most recent Australian Data Registry 21 report. And of course, all of these outcomes are due to improvements in care, new therapies. Of course, we have to mention that CFTR modulated therapies have made a dramatic impact on CF in the past few years. However, these also pose us new challenges and learnings for people with CF, and that really was the context in which the conference started for this year. So this is an overview of what we are going to try and cover today. Now, I should mention that this is not everything that was covered at the conference. There was certainly lots and lots and lots of topics, but what I've done is just choose the main areas of interest and the really topical areas that were spoken about a lot at the conference, which we'll touch on today. So we'll try to discuss changing models of care and de-escalation of care, nutrition and physiotherapy, fertility, sexual health, pregnancy and breastfeeding. We'll talk about lung infections. We are definitely going to focus on gene therapy because we recognise that not everyone is eligible for a modulator therapy, nor will be able to benefit from them. So looking at gene therapy as a solution, no matter what mutation someone has. And of course, we will focus then and finish up on mental health. So with that in mind, let's get started. One of the things that came up immediately was the idea of changing models of care. So recognizing that a lot has happened in the CF space. We know that survival is increasing. We know that on average, people are doing a lot better due to new modulator therapies. So then we need to ask ourselves the questions, well, how often then do we need to do clinic visits? Does it still 4 times a year? How often do we need to do respiratory cultures, pulmonary function testing, and so forth? How do all of these changes that we're seeing on a population level mean how we're looking after people then in the health system and on the systematic level? So really, we're trying to find the balance between how do we maximize someone's health and clinically, whilst also minimizing the burden for people with CF. So not having to go in if you don't need to. And it will come as no surprise that the consensus is that this is highly dependent on things like modulator status. So of course, someone who is, for example, on Trikafta has very, very stable and high lung function, maybe having conversations with a clinic team where they actually discuss that maybe, going in once or twice a year is actually okay for them. And that's completely appropriate given their situation. However, someone who might not be on modulators or who may not be responding, that things are going to look quite different. So of course, we need to recognize that care needs to be tailored to individual needs. And it will likely come as no surprise, and I'm sure that we have the similar here, that there's very mixed community perspectives around this. So there are different comfort levels associated with how often you go into clinic and see these things. And so I thought it was really interesting. We heard from 2 consumers at the conference, and I pulled out these quotes, and one of them was from a 45-year-old woman living with CF. She was on modulator therapy, and she was doing really well. And so she said, well, I love seeing my clinical team, but not that regularly. I'm good, I'm great, I feel really good. And so she had discussion with the care team, and they reduced the number of times that she was going into clinic. However, a very different opinion was a 62-year-old woman with CF, also on Trikafta, also had stable lung function. But she said, please don't change things because they're working. She associated the fact that she had been very meticulous with her care to the fact that she had such great outcomes. And so she didn't want to see any shifts in the way that was approached. And so, of course, we recognize, again, that every person is going to be different. And really, this is up to the individuals to have those conversations with their clinical teams to figure out what works best. Now, that's on the systematic level, so that's on the healthcare level, but what about on the individual day-to-day level? One of the things that's been talked about a lot is around de-escalating care. So we have seen very, very, very frequently in the recent year or two, and this is not just Australia, this is very much a global occurrence, is that some people are stopping chronic daily therapy when they are taking Trikafta. And of course, it's really important to note that the people who are often stopping this chronic daily therapy are those with increased lung function and who are doing quite well on this therapy. We do know that that's where the rates are associated. And so when we look at this, we think, okay, well, if someone's doing really well on Trikafta, potentially there might be a way that the daily therapy can reduce. The important thing to note here is that is not a decision that's made on the whim. It's really important to have that shared decision making with clinical teams, and clinical teams are having these conversations a lot. It's very normal. It is happening everywhere because, of course, we're recognizing that in some instances, it actually is appropriate to have some time, back in the day, instead of doing X number of hours, that might be reduced, and that's okay, that people don't experience any changes or any detriments. But again, really, really important to talk to clinical teams because they'll often say, let's trial this out, but we're going to really closely monitor it to see if this has any impact and adjust as necessary. Really interestingly as well, this was study data that came out of the US data registry. This was literally published this month. So it's the most recent 2022 data. And we can see that actually exercise is becoming a primary method of airway clearance for people on a higher rate as well. So again, if we're thinking about how care is changing and how we approach this, using exercises is certainly something that is increasing and is being shown to be incredibly beneficial as well. One of the studies that they did present on, which I found quite interesting, was the Simplify study. And this study looked at the impact of discontinuing hypertonic saline and Dornase alpha in a group of people who were on modulator therapies. So specifically, these people were on Trikafta, and it was a 6-week study. And interestingly, what they found was that in those 6 weeks, there was no difference for participants who had discontinued those therapies with regards to their outcomes and their mucociliary clearance, which is the movement of mucus out of the lungs. Now, very importantly, this is interesting, but it's a 6-week study. So whilst we can look at that and say, okay, there might be some learnings there, we really need further research around, what about at 12 weeks? What about at 6 months? We really need longer follow-up to be able to really integrate this into our practice. We do also require a lot more diversity in this study. So would be really great to know the diversity of people with different types of lung function and how they responded to this. And so again, there's lots of research that is happening at the moment. Very interestingly, a part of this study, actually, there was a sub-study of about 34 people where actually they had an increase, a 6% increase in mucociliary clearance in those who stopped the Dornase alpha whilst on Trikafta. So again, lots of things that could potentially be happening there, but further research is required. Now, let's jump to a different area, and that's nutrition. And the way that we approach nutrition is very much changing in CF, and that's largely due to new medications, not just modulator therapies, but of course enzymes and so forth, which means that people are able to absorb more calories from food. With people doing better in terms of lung function, we're also not expending as many calories. So approaches to nutrition is definitely changing. And I do like a good pun, so I couldn't help myself. So wait, there is more to the story. And of course, we recognize that in the past, there has been this real hyper focus on weight. And we can understand why, because in the past, one of our major concerns was malnutrition in people with CF. However, now that with improving outcomes and so forth, we're starting to shift the importance to take into consideration other metrics apart from just weight. We do also know that treatments that focus on weight are associated with higher instances of restricting or binging food, missing enzymes, insulin laxatives, and so forth. And so recognizing that actually, let's take a step back and look at, well, not just weight, but body composition. What is our bodies made up of? How is your fat mass compared to your lean body mass, your muscle mass? Let's focus on just basic health education, get down to basics. And again, the instance of eating disorders, which we know are actually much more prevalent in the CF population than compared to the general population. So, of course, emphasizing prioritizing habits. So again, looking at body composition, dietary intake, so intake of fruits and vegetables, fiber, tobacco usage and minimizing exposure to that, increasing exercise, and of course, minimizing alcohol as well. It seems really basic, but actually a lot of these things have been missed in a lot of CF education, and so it's important to bring them back in this instance. Now, I do actually want to take slightly bit of a detour and focus specifically on this tobacco usage. There was a CCF study that was presented at the conference by researchers at the University of Alabama, Birmingham. And what this study told us is about a third of children with CF in the US are exposed to tobacco smoke. And we don't have the data to tell us what the Australian equivalent is, but that's quite high. And from that study, we recognize that actually this exposure to tobacco smoke does result in a 5% decrease in FEV1 or lung function by the age of 6. So that's quite startling. However, there is a bright side, and that is with a year of cessation of smoke exposure. So in this case, it was families who were giving up smoking, other members of the family who were giving up smoking and ensuring that that child was not exposed. By 1 year of cessation, there was a 17% drop in pulmonary exacerbations for those children. So again, emphasizing the reduction in tobacco exposure, smoke exposure. We haven't touched on vaping, and I think a lot is going to come out around that over the next few years, because of course we know at the moment vaping exposure is actually higher than tobacco and smoking, and so this will certainly have impacts and things that we need to consider. And finally, an aging population. We do have an aging CF population. It's a great problem to have when we're looking at comorbidities. And of course, comorbidities is something that we need to consider. And with increased age is the increased risk of cardiovascular disease. The next thing that was quite interesting in nutrition is understanding the idea of body dissociation. And so when we think about lots of people growing up with CF, a lot of people reported that copious eating and overeating in childhood, trying to get as many calories in, so developed practices such as mindless eating. And this has led to a sense of body dissociation. And so it's actually a protective mechanism where we distance ourselves from our body. We're talking about it in the case of nutrition, but actually it could also be relevant with medical interventions and so forth. The idea of dissociating yourself from one's body can be a real protective mechanism, especially when undergoing such high instances of care and trauma in the medical space. And so really these practices need to start being unlearned and be treated, because it's certainly something that's carried with us throughout our lives. And so we recognize the importance, and there's a lot of discussion happening around trauma-informed care. And again, we are looking at this in the context of nutrition, but it's appropriate across all areas of the CF care space. As part of this, we recognize that everyone has a body story. And I quite like this narrative, and it was quite, I think it was probably one of the most interesting talks that I actually attended, was around looking at one's body story and how it's defined by the media, conversations from healthcare professionals, family members, but also what we tell ourselves. It's our internal narrative. And so the idea that we can really address this by taking back control of that narrative. And I thought that this was a really lovely quote from the researcher at hand. She said, what would a story told through the lens of self-worth, respect, and self-love sound like? And using this really to rewrite that narrative. And of course, recognizing that there is power in storytelling, and that is a way, and quite an effective way, to be able to do that. If you have not seen CF Strong and had a look at that website, I would really encourage you to do so. CF Strong is a place where it's an incredible resource center, but it has some really, really wonderful articles written by people living with cystic fibrosis in Australia. And there's some great storytelling there. So I would encourage you to look at that after this if you have not already. And finally, the last concept, which really ties into this whole narrative, is embodiment. And so embodiment is the act of trusting and listening to the body instead of ignoring it or overriding it. So really trying to reverse back that body dissociation that happens often as a result of things that happened in CF care earlier in life. And so the idea of embodiment is, shifting that focus from doing things to or on the body to doing things for and with the body. So again, something that's quite interesting. And if you're interested in learning more, I'd really encourage you to talk to your dietitians and nutritionists. They have, I'm sure, will have some really lovely tips on how to integrate that into your everyday life. Let's shift now to physiotherapy. And physiotherapy, the talks were at 7 a.m, which I really appreciated the fact that all physios would get up that early, but there was such incredible insights and presentations on what was learned. One of the things that I think we'll touch on and what I found quite interesting was around the discussion of fat-free mass. So again, this is kind of leading on from what we was talking about in nutrition, in that there's more to the story than just weight. And similarly, when we look at that, we look at body composition, a really key component of that is fat-free mass. Now, fat-free mass is also termed lean body mass, so you may have heard of that. But essentially, it's exactly what the title says. It's the mass of the body which does not include fat. So it's your water, the organs, your bones, muscles, blood, connective tissues, and so forth. And we recognize that actually a higher fat-free mass, so having more higher, bone density and muscle mass and less fat, is actually more highly correlated with lung function than BMI is. So BMI can be quite useful, but there are certainly challenges and limitations, and that's because BMI only takes into consideration height and weight. So it neglects the components that actually make up that weight. So for example, if you had two males which weighed 80 kilos each, one has a body fat percentage of 25%, the other has a body fat percentage of 15%, clearly we can see that their body composition is not comparable. There's definitely more to the story. And so using fat-free mass as a metric can be a really good tool to understand that. Now, leading on from that, if we know that fat-free mass is correlated positively with lung function, and we want to increase lung function, of course, that leads us to recommendations for resistance training, because a great way to increase lean mass is through resistance training. And so really, really interesting discussions here around the fact that, well, the level of exercise that's required to see benefits may not actually be as high as what we'd originally thought. And so someone did present on this research study that was by Holmes 2022 and colleagues, which actually took two groups of people with cystic fibrosis. One group trained for 2 to 3 days per week with resistance training, the other trained for 4+ days. And they actually found there was very minimal difference between the two groups. And so what this tells us is that actually, in terms of barriers to entry, we don't need to be training necessarily 5-6 times a week, to see those benefits. Actually, we can see a lot of those benefits in just 2 to 3 days. Now, in saying that, if you do want to train 5-6 times a week, please go ahead. But this is great because essentially what this study is telling us is that we're reducing the barriers to entry. Now, really importantly, adherence is the most important thing when it comes to exercise. And so choosing an exercise regime that people will enjoy and therefore be able to maintain consistently over a period of time should really be front of mind. So do encourage you to talk to your physiotherapy around what they might recommend. But of course, it's recognizing, well, what program is going to allow you to be able to do that consistently and get enjoyment out of. Otherwise, adherence, we run into adherence issues there. And the final point that we will touch on is that about 13% of people with CF are now considered obese. So again, this really ties into the conversation that we're having before around nutrition and changes in that space. We also need to recognize that obesity is something that has negative detrimental health outcomes. And so, of course, we need to do everything we can to maximize the efficiencies to keep people in a healthy body weight. And that's generally the result of that beautiful interplay between diet and exercise and those healthy habits. Now let's talk about fertility and sexual health. And you might be thinking, well, why are we talking about this in a CF context? And this was such a topical area. I think there was about 2 sessions that focused purely on fertility and sexual health in this conference. So it was quite stark. And there's a reason for that. There was an 8-center study that was conducted, and which had hundreds of people living with cystic fibrosis who were a part of this in the States. And in this survey, they found that 83% of people with CF considered their CF clinic teams to be their primary health provider. And nearly half of them did not have a primary health provider, so a GP. And we do see this where we know that it's really great for someone to have a GP. We do really encourage it. But we do know that a lot of people do rely on their CF clinical teams to be their primary provider. And so fertility and sexual health discussions naturally are going to be an incredibly important part of that. Now, this study did also highlight some gaps in knowledge and tells essentially healthcare professionals and people like us that we actually really need to do more around education. So in this study, 15% of males didn't actually know that they could have biological children. And this was a quote from one of the participants of the study who said that through my 20s, even when I was married, I felt like we really wanted a child, but they didn't think it was possible. And that knowledge that you can have a biological child with CF has to come a lot sooner. And so, of course, we recognize that this relates to the fact that males with CF are born with the congenital absence of the vas deferens, which is responsible for the movement of mature sperm to the urethra. And so this is absolutely possible for males to still have biological children because of the incidence and accessibility of artificial reproductive technologies. Another thing that did come up as well around fertility was the female part of the equation. And so we do know that about 1/3 of females with CF who attempt to conceive experience infertility. Now, let's firstly define what infertility is. It doesn't mean that you can never have a child. Infertility is defined as the inability to conceive after 12 months of regular unprotected sexual intercourse. And so the incidence of this in CF could be due to a number of factors. It could be due to decreased ovarian reserve, malnutrition impacting ovulation, cervical mucus thickening, acidity levels, and so forth. But really importantly, when surveyed, the CF community essentially were crying out for to answer this question, which is what is the effect of modulators on sex hormones, on pregnancy and fertility? So in the context of everything that we were talking about, this is an area that was seen as a huge area of focus. And we certainly do need a lot of research in this area. And what I'll try to do is go through some of the case studies and some of the learnings that they did discuss at the conference. Let's start with pregnancy and breastfeeding. And this is incredibly important because you may have seen this graph, but I think this is probably one of the most stark examples of the impact of modulator therapies. this is the number of pregnancies in the US for people living with cystic fibrosis. And again, from the registry data, you can see here that from 2019 to 2020, the number of pregnancies almost doubled. And that correlates directly to when the Trikafta became available in the US. You can see that those levels have not come back down. They've stayed pretty consistent. And so in Australia, we have also seen a very similar thing. We obviously didn't get Trikafta as early. However, we definitely have seen in the last year or two a pregnancy boom with people on Trikafta able to have children, which is fantastic. It's amazing. Now, it's important to note that of this registry data, 40% of these pregnancies were actually unplanned. And this is incredibly important for us because we know that unplanned pregnancies do experience higher pulmonary exacerbations compared to those that are planned. And so really encouraging those conversations with the clinical teams around, do you want to be a parent in the next year? Being able to prepare for that as well, we know is improving outcomes for mums going through this process. Now, the other thing that comes up a fair bit is the question to take or not to take, and that refers to CF modulators during pregnancy. I think we have heard this question almost every few weeks this year because we don't have answers. And this is something that we really, we're waiting for clinical trial data to come out around this that will give us some really concrete solutions and answers to this question. But currently what we're running off is observational data and case studies. So when we think about this, we need to consider, well, what is the risk to mum? So if mum is on a CF modulator, what is the risk of stopping that modulator? What does that mean for her lung function and her pregnancy? Similarly, you also have to think about, well, what is the risk to the infant? Because we do know that CF modulators have the ability to pass through the placenta in quite high concentrations and also in breast milk, though at lower concentrations than in utero. So I'm going to go through 2 case studies which was presented, which were very interesting. Again, these are case studies, so n=1. This is not a trial, but some interesting insights into what is happening. And so the first case study was with a mother who was a carrier, so she did not have CF, but she was pregnant and baby was diagnosed with CF in utero, so whilst she was pregnant. Now, she was able to access Trikafta, the mum was able to access Trikafta. We're going to pop that aside because the US is a wild and crazy place where a person who's a carrier was able to access it. But looking apart from that, she did take that medication during the course of her pregnancy. And so baby was exposed to Trikafta in utero. Really interestingly, what happened when baby was born is that they came up with a false negative on newborn screening. They had decreased sweat chloride values. They had normal fecal elastase. So these are all usually markers which we look at, which will tell healthcare professionals that a baby has CF, which were coming up quite normal. But really interestingly, and this is the thing that got me, was that baby on a scan actually had, he was a boy, had a palpable vas deferens. And so if we think about just a few moments ago, one of the primary cause of infertility in males with cystic fibrosis is the absence of this structure. And so the fact that this was palpable on a screen on ultrasound was quite interesting. And of course, more follow-up is required for this case study and others. A second case study was also presented, and this was a mother with CF who was taking Trikafta. And the child was also diagnosed with CF in utero. So both mum and bub both had CF, and she was taking Trikafta in utero. When the baby was born, baby was thriving, doing really, really well, hitting all milestones, but mum couldn't breastfeed or didn't breastfeed. And so baby was no longer exposed to Trikafta because he or she was not getting breast milk. 6 weeks after birth, baby was presented back into hospital, had malabsorption, pancreatic insufficiency, and pulmonary exacerbations. And so really what mum was saying, and it was incredibly interesting to hear this from mum. She said, you could see the modulator leaving their body. And of course, the results from that. We do know that newborns are not approved for Trikafta, that age group is not eligible. And so without breast milk, there was no way for that baby to continue receiving it. We do know that there are risks. So we do recognize that we are definitely waiting on data and clinical data, clinical trials. We do know that abruptly stopping modulator therapies can exacerbate pancreatitis in some instances. And we do know that some infants, there are concerns around cataracts and so forth. So again, we really just need clear clinical data, and there are clinical trials that are happening in the States around this as well. So hopefully we will have some answers soon. But until then, this has been, I found this incredibly interesting. Let's change gear again. And let's talk about lung infections. So this was a graph that was published in the US Data Registry. And you can see here, this is the number of cultures that were produced per person over a 12-year period. And you can see that abrupt drop that happened from 2019 to 2020. That's generally thought to be the result of the pandemic. So the fact that of the pandemic isolation, there were less cultures that were created per person. But you can see, interestingly, that rates haven't gone back to normal. And of course, one of the reasons why this is thought to be the case is because people with CF are producing less sputum, which is how, through the collection of sputum, we typically test for bugs and inform antibiotic therapy. And when we say that people are producing less sputum, it's people who are doing a lot better on things like modulator therapies who are producing less of this. And so without the ability to, with these changes that we're experiencing, questions asked, well, okay, how do we test for this? How do we test for bugs? And how do we inform antibiotic therapy? And so some of the research presentations that were discussed really focused on alternatives. So this included collecting sputum at home. So you might not present it at clinic, but maybe at home you might be able to bring some up. Certain sputum induction techniques, potentially using some breath biomarkers, which was incredibly interesting to see what exists in the lungs. And there was even some research looking at biomarkers in the blood to diagnose what bugs might be prevalent in the lungs. So very, very interesting stuff happening there. And of course, the second thing that we think about when we relate to lung infections is recognizing that with the high usage of antibiotics in the CF population, there are concerns that come around about antibiotic resistance. And this is not unique to the CF population. Antibiotic resistance is a global issue, but definitely in the CF population with the high exposure to antibiotics, this is something we need to be really mindful of. And of course, coming on from that, we want to treat people in the best way, so not the most intensive, and there's a difference. So really interestingly, there's been some research, specifically the STOP observational and STOP 2 observational programs, which have looked into antibiotic administration and specifically looking at potentially shorter durations with less toxicity for equal outcomes. So some really interesting research coming out there. The other thing to note on this area is recognizing this is the prevalence of bacteria prevalent in people living with cystic fibrosis and the rates of infection with said bacteria. And so you can see that for all areas, it's actually dropped from 2018 to 2022, which is fantastic. Now, we have to recognize that in this time period, there was the pandemic, so people were in isolation, less exposure. But this could also, and is thought to also be a result of CF modulator therapies as well. Now, we've talked a lot about modulator therapies, but we cannot ignore the fact that lots of people are not eligible for them. Some people it won't work. And also that some people, whilst they might be eligible and get on them, they actually have negative impacts and side effects, and so they have to come off. So one of the things that's really, really interesting and incredibly exciting in this space is gene therapy. And what's so exciting about gene therapy is that these are strategies that will allow us to achieve CFTR restoration for all people with CF, regardless of mutations. So we know that there are over 2,000 different mutations in the CFTR gene that can cause CF, and these fall into different classes. And so if we bring up this image here, this is how CFTR generally gets produced. So in typically the DNA, the CFTR gene gets made into RNA, gets folded into a protein, CFTR protein, which then moves through channels and so forth and does its thing. Now, of course, in CF, we do have mutations at this DNA level, which means that this process is disrupted. So, for example, with class 1 mutations, there is actually the process is disrupted here. So actually there is no functional CFTR protein that is able to be created. For class 2 protein, class 2 mutations, the protein is created, but then it misfolds. In class 3, the protein is created, but is unable to make it through the channel gate, and so forth. So clearly there are lots of different ways in which CFTR is operating in terms of the different classes of mutations. And currently, our modulator therapies look at solving these issues on the protein level. So when we talk about the fact that 7% of people will not be able to have a clinical benefit from CFTR modulators, we're talking about the 7% of people who actually don't even produce any amount of CFTR protein. Therefore, the modulator has nothing to work on, and therefore it won't work. So gene therapy really looks at treating CF at the step earlier, and that's looking at the DNA and the RNA level. So let's look at the two types of genetic therapies for CF, or two categories, I should say, for which these therapies fall into. The first is called gene addition therapy. Now, gene addition therapy comprises of techniques like mRNA and gene or DNA therapy. Essentially, what the aim is to deliver functional CFTR, either mRNA or DNA, to cells. And I might actually go back and just highlight that on here. So what this type of therapy tries to do is to insert into cells functional copies of the DNA or the mRNA alongside, so we're not replacing anything. The existing CFTR mutations are there. We're actually just injecting functional copies of DNA and RNA, which then are able to be reprogrammed by the cell's machinery and is able to produce then functional versions of the CFTR protein. Now, because we are not changing any of the actual machinery, we're just adding something in, this will require redosing. So we do recognize that likely it will be probably either daily or weekly, monthly. We're still trying to figure out how often that will be, but it's not a permanent solution. It will require the upkeep. However, the second class is gene editing. And gene editing, and I really like this image because I think it shows what happens, but obviously not with a pincer, although that would be quite useful. So gene editing really tries to go into at the level of the DNA or the CFTR gene and cut, edit, and repair that gene, specifically looking at those mutations and fixing those mutations. And this is often done with things like CRISPR technology, and there are a few others. But the great thing here is that it could be permanent for the life of a cell. And if the CFTR gene can be corrected in the DNA of lung stem cells, then gene editing could actually result in a permanent cure in the lungs. So incredibly exciting stuff that's happening. And I think it's really important that, this isn't theory anymore. It's happening. And so gene therapy is very much becoming a reality for CF. I pulled this morning. And this is a list of the current gene therapies for CF, which are in development. And you can see that actually there are 4 of them that are in phase 1 clinical trials. This means that they are being tested in people for safety and efficacy already. These are small groups, but they are happening. One is about to begin. And then all of these other therapies here are still in preclinical development and waiting for extra data and development before they can enter into clinical trials. So, like we say, gene therapy has been talked about since the CF gene was discovered, but really now we're starting to see that become a reality. And we can take lessons as well from other diseases such as sickle cell. We did actually hear at the conference from one of the researchers in this area where they are utilizing gene therapy right now. And actually one of the compounds that they have, which has seen amazing results, 97% of people who received this gene therapy reported pain-free experiences after gene editing. So really incredible stuff. So not gene editing, they got gene therapy. Important distant clarification there. Now let's finish off with an incredibly important area, and that is mental health. And I really love the fact that the last plenary, there was 3 plenaries. The last one was actually titled "There is no health without mental health." So really recognizing the importance of this, and it's relevant because in people with CF, we do know that depression rates are 2 to 3 times higher than the general population, and about 37% of parents, 19% of adults, and 10% of adolescents with CF do experience depression and or anxiety, and that's the result of the TIDE study, which is a landmark study in mental health in CF. We do also know that this is the data registry data. This is the most up-to-date that we have. Actually, from 2018 to 2022, we have seen increased levels of depression and anxiety reported in the CF population. And again, that could be due to lots of factors. We did have that small thing called the pandemic in there, and which was very, very difficult for everyone, particularly people living with cystic fibrosis. So this is definitely an area which we need to continue to focus on. In particular, one of the studies that was presented at the conference was the Wellness in the Modulator Era study. And this was a study with 900 participants, all of whom were taking modulators. 571 of those were taking Trikafta. And they asked everyone this question, which was, have you or your child, so parents were answering for if their children was also on a modulator, have you or your child experienced changes in the following areas since starting a modulator? And they brought up overall health and quality of life. And you can see from this data that it was overwhelmingly quite positive. Not all, because of course we recognize there are some people who do experience worse outcomes as a result of modulator. You know, everyone responds very, very differently to every drug. However, overall, on average, people did respond that things were better. Improvements had experienced improvements in overall health and quality of life. However, when we asked that same question for anxiety, agitation or irritability, thinking clearly, so brain fog, depression, and sleeping difficulties, it's a very different story. So we can see here that there was a lot more variability in how people responded to this question, with some people certainly experiencing a fair bit of side effects as a result of or corresponding to starting a modulator therapy. And again, there are lots of things that could factor into this. So for example, the COVID pandemic, which did overlap with this survey, the psychological impact of starting a new therapy, so maybe it not doing what we expected, even if there are positive outcomes, maybe not knowing and anxieties around how long that's going to last, changing body image. There's also drug interactions, life events happen. And there's also, the direct impact on the brain. So, binding neurotransmitters or by changing potentially chloride levels in the brain that could impact on mental health outcomes. And so clearly, lots more research is required in this area. And it's something that we'll continue to keep a really close eye on. I will also say if you are experiencing any changes with being on a modulator to your mental health, you are certainly not the only one. I think that's really clear from the research. That is a very common thing to experience, and so it's really important to talk to your clinical teams because there are lots of things that they can try and do. So lots of clinicians were talking about the fact of starting on potentially like psychotherapies, looking at reducing dosing or changing timing of taking modulators. There are lots of other ways that that you can address that, and so, but it's obviously important to have those conversations with your care team so that they are aware. And with that, I'm going to stop talking for a moment, and I want to thank you all so much for your patience. We will get into questions. So if you haven't already, and I will stop sharing my screen so that I can actually see what's happening in the Q&A in the chat. If you haven't already, please do pop a question in the question Q&A below. I will also leave this up for a second longer, just recognizing that if you do have any other questions after today, as it relates to anything that I've spoken to today, any other research that's happening in this area, if you need support, I have put in our general support email, which will take you to our incredible support team. And of course, if you want to talk to me directly, I'm always happy to talk about research and anything support related. And if you do have any feedback, please feel free to contact me directly as well. That is my direct email. Thank you so much, Shani. Thank you. Yes, Shani, my role is I'm the head of programs and research at CFCC. So my background is in medical sciences. I have a degree in medical genetics as well. So I had the absolute pleasure of working with many CF families across a few hospitals in New South Wales before I started on research and started into this role. So I've been in this role for about almost actually more than a year now. That's gone very quickly. So it's been wonderful. So thank you. I'm going to stop sharing my screen. There we go. Oh, and I can see me. Please feel free to pop anything in the chat. We do have time. I actually was worried about time, to be honest, but it's good to see that we've still got a little bit left. Our team did make fun of me when I did do a presentation to the all staff around this, and I almost took up the entire meeting because I feel like there is so much happening in this space. It's incredibly exciting. But of course, as you can see, there's still a lot for us to learn. And so it's that constant balance between looking at what we have, but also needing more research as well to guide what we're doing. Thanks, Shani. That's fantastic. And I hope you haven't said if it's who they are, but I hope your little one, not so little one, is doing well. So I'm glad you found this useful. I'll give people a few more minutes to see if you have anything else. It's quite disconcerting because I can't actually see anyone, but I can see that people are on. So I hope you have found this useful. Like I say, I will actually, and I'm going to put it in right now. If I can, yes, I can type it to everyone. I'm going to put those emails back in the chat. If you do have any other questions after today, that is our support email. And I will put I'll put my one in there as well. There we go. In case you don't have any questions now, but they come up later, like we say, we'll always be here for that. All right, I can't see any other questions. So we might actually leave it at that. I want to thank you all for attending. It was pretty late notice actually that we put this together, and it's been I've certainly had a great time. I love this stuff. I think it's an incredibly interesting and exciting area to be working in at the moment. And of course, really exciting for everyone else as we start to see all these changes happening, and of course, interventions that we've never had before, and all these key learnings that can help us improve outcomes for people now and people in the future. So thank you so much for dialing in. I appreciate it. And to all of those who will be looking at this at a later time at the recording, I wish you all a very, very, very safe and happy holidays and all the best for the new year. And thank you so much again. Bye, everyone.